Hi, we are here with Dr. Joel T. Funk from the BUMC in Tucson, Arizona. He's an expert in whole lip, prostate enucleation, and surgery and pelvic surgery for incontinence. So thank you very much for accepting this interview. I'm going to ask a few questions very quick. So first, what is your position regarding some techniques as en bloc technique, two-lobe technique, and three-lobe technique? Is there any technique you prefer?
Well, first, thank you very much for the invitation to be here for the meeting. It's been wonderful so far. Regarding technique, two-lobe versus three-lobe, I'll group together because they are fundamentally different than an en bloc technique. My opinion has kind of evolved on this. I think that if someone is learning enucleation in a structured mentorship environment, whether that be a resident or in a fellowship somewhere where they have someone that's an expert to guide them, I feel that en bloc yields a couple advantages. The first is that it establishes that single plane of dissection initially in the operation. And so for a learner, having that done early, it really becomes just maintaining that plane of dissection throughout the enucleation. But I would say that the disadvantage of that, and why I would say for someone who's looking to adopt enucleation on their own, is that from a technical standpoint, that the dissection on the anterior urethra at the apex, it's technically challenging. It's probably the most difficult part of the operation. And accomplishing that safely and feeling comfortable that one is at the apex but not too distal without some reassurance from someone who's done it many times is difficult. So for someone who is looking to adopt enucleation, who has been practicing for a few years or decades, the advantage to a two or three lobe technique is that it partitions, it splits the operation up into manageable pieces. And those allow you to assess your progress, but also have a way to bail out. And so if you're going to do a two-lobe technique, I recommend people put themselves kind of on a clock and say, I'm going to give myself 45 minutes to do enucleation of the left lobe. Mm-hmm. And when they get the enucleation done, check, did it take me 45 minutes or did it take longer? And if you're at an hour and 20 minutes, perhaps the right thing to do is to either go to a traditional TUR technique for the other lobe, or I would even say leave it and move on to morcellation. And that's the other part of this is when it's partitioned into those segments, if you get the median lobe out, the literature says patients are going to do well. And thusly proceeding to those lateral lobes, if you've had a real struggle just with the median lobe, may be unnecessary. So I think it depends on how someone's adopting. But certainly for trainees, at our institution, we teach entirely en bloc now, and because I think conceptually it makes more sense to learners.
Of course, thank you. And do you think there are any other indications or restrictions regarding selection of one of these techniques outside the training curve?
I think that probably the biggest criteria for how you want to approach a gland is probably prior intervention. You know, many of these patients that we see have had a prior electrical TUR, whether that be bipolar or monopolar, or they've had a PVP with a green light and a TUR, or they've had 2 urolifts or some other minimally invasive therapy, and so those sort of complexities I think sometimes do dictate. At a recent example, I had a patient who had a prostate artery embolization done 2 years ago and had really significant residual adenoma just on the right side of the prostate. And so we utilized a two incision technique to take out that right lobe and alleviate the residual obstruction. So I think that when you get into those more improvisational environments, that having the ability to move between a 2 or 3 lobe and an in block is helpful. But if someone, certainly I'm an example that if you learn 2 or 3 lobe, which I did and practiced for many years, if you've mastered that, moving to an in block technique in your process and growth as a surgeon, I don't think is overly difficult.
Thank you. And what's your position or experience between whole lip and tooth lip?
I appreciate the question. We actually have just gone through the process over the last 15 to 18 months of looking at and trialing the fiber-based systems. Across the board for all of them, my thoughts are, one, it's extremely quiet. The systems are smaller. It's almost disturbingly quiet if you're used to using a high-power holmium laser, which is really nice. More portable to different facilities or different operating rooms within a facility because you don't need a high-power outlet. That 50 amp service is not required. But I will say from a technique standpoint, I think the fiber-based systems are a little bit slower. Whether that's statistically significant, I think that it depends on what study you want to look at, but is, at least in my hands, a little bit slower. And I do think that because the laser is, in my opinion, more of a cutting laser, maintaining the surgical capsule, if you're using laser only, becomes a little bit more challenging. And so for me, as I learned through FLEP, I felt like I had to use more mechanical or blunt dissection just to kind of make sure I'm maintaining my dissection on the true capsule. But obviously, it's an incredibly biased opinion. I mean, I've done probably 100 through FLEPs across 5 different platforms, and that can't compare to many more with holmium based.
Thank you. One last question. What do you believe are the future perspectives in anatomic and enucleation of the prostate? What do you think is the role of AI taking in this field?
I think that you ask an incredibly timely question. If I was having this discussion with another urologist in the States as we were brainstorming, and I truly think that I believe within my career, which hopefully I got a couple more decades to it, I think we will see a revolution in how we approach the operation. We will have modeled these operations based on MRIs in a software system where AI will have done the operation 1,000 times. And you combine that with whether it be augmented reality or whether it's combined with transurethral robotic systems like the Virtuoso system that they're developing at Vanderbilt, where we basically are following a roadmap. I still think that there's a role for actual hands-on surgeon running the equipment, but the simulations will allow us to have that roadmap, and if we need to deviate it, that becomes an expert opinion interoperatively. But AI and miniaturization of robotics is where I think we'll go in the next 10 to 20 years.
Thank you very much. Thank you, Dr. Funk, for this short interview. Thank you for your time, and thank you for accepting this.
Yes, thank you so much.